Good morning, distinguished guests, ladies and gentlemen. Welcome to the Advances Disease Detection, Diagnosis and Treatment panel of the Science for Life Symposium. And this is the event in the framework of VinFuture SciTech Week, VinFuture Prize Award Ceremony 2025. Welcome all of you. Thank you so much for your coming. Distinguished guests, ladies and gentlemen, the VinFuture Prize is prestigious global science and technology award, proudly originating from Vietnam. The topics we will explore in today's panel are essentials for advancing global scientific progress and have profound implications for our life. Vietnam is deeply committed to supporting scientific development and is playing an increasingly influential role in the world stage. As we may know, we are witnessing a new era in healthcare driven by technology, data, and innovation. Artificial intelligence, biotechnology, and smart medical solutions are transforming the way we diagnose, treat, and care for patients. Advances in cancer research are improving early detection and treatment outcomes, while developments in antibiotics and infection control are addressing growing global health challenges. And these innovations are opening opportunities to enhance the quality of our life and shape the future of healthcare worldwide, and to promote scientific and technological knowledge to the public, and also connect generations of young scientists, inventors, and entrepreneurs, and especially with the globally established inventors for potential partnerships. This event is held with the participation of distinguished speakers who have excellent expertise and experience in the field of medicine and health. And to come to our symposium today, it is our privilege to introduce to you our distinguished guests. First, representing the government of Vietnam, it is our honor to welcome Dr. Nguyễn Ngô Quang, Director of Department of Science, Technology and Training, Ministry of Health. Thank you so much for coming with us. Second, representing the VinFuture Foundation, please welcome Dr. Lê Thái Hà, Managing Director of VinFuture Foundation. Thank you so much. And last but not least, it is our honor to welcome Professor Quarraisha Abdool Karim, Chair of today's symposium, and also the member of the VinFuture Prize Pre-Screening Committee, Center of AIDS Programming of Research, South Africa and Columbia University, USA. One more time, thank you so much for your presence. Distinguished guests, ladies and gentlemen, and now it is my great honor to invite to the stage Dr. Nguyễn Ngô Quang, Director of Department of Science, Technology and Training, Minister of Health, to the stage to deliver his opening speech. Please join me in welcoming him to the stage right now.
Kính thưa giáo sư Richard Henry Friend, Chủ tịch Hội đồng Giải thưởng VinFuture. Kính thưa các vị khách quý, kính thưa các nhà khoa học, các đồng nghiệp trong nước và quốc tế, kính thưa toàn thể quý vị. Hôm nay chúng ta có mặt tại buổi tọa đàm chuyên đề về chuỗi tọa đàm khoa học vì cuộc sống trong khuôn khổ tuần lễ trao giải thưởng VinFuture 2025, một trong những giải thưởng khoa học toàn cầu có sức lan tỏa mạnh mẽ, tôn vinh những đóng góp đột phá nhằm cải thiện chất lượng cuộc sống của con người. Sự hiện diện đông đảo của các nhà khoa học xuất sắc từ nhiều quốc gia khẳng định sự phát triển bền vững của cộng đồng khoa học toàn cầu và vai trò ngày càng quan trọng của Việt Nam trên bản đồ nghiên cứu khoa học quốc tế. Kính thưa quý vị, năm 2025 đánh dấu một thời điểm đầy biến động của y tế của toàn cầu. Nhân loại tiếp tục đối mặt với những gánh nặng sức khỏe toàn cầu ngày càng gia tăng và phức tạp. Trong đó, tỷ lệ mắc các bệnh không lây nhiễm, đặc biệt là ung thư, tiểu đường, các bệnh tim mạch tiếp tục gia tăng mạnh tại nhiều khu vực. Các bệnh truyền nhiễm tái nổi và mới nổi gây áp lực lên hệ thống y tế, nhất là trong bối cảnh biến đổi khí hậu làm gia tăng nguy cơ dịch bệnh. Tình trạng kháng sinh đang tiến gần đến mức báo động, đe dọa làm đảo ngược nhiều thành tựu y học trong nhiều thế kỷ vừa qua. Sự chênh lệch về tiếp cận dịch vụ y tế giữa các quốc gia và nhóm dân cư ngày càng rõ rệt, đặt ra các yêu cầu cấp thiết về đổi mới sáng tạo để tạo ra các giải pháp y tế chính xác, hiệu quả và bền vững hơn. Tuy nhiên, song hành với những thách thức là những cơ hội chưa từng có từ những sự bùng nổ của công nghệ số, của trí tuệ nhân tạo, của công nghệ gen và vật liệu sinh học trong chẩn đoán và điều trị bệnh. Trong bối cảnh đó, chủ đề của buổi tọa đàm ngày hôm nay, bước tiến trong phát hiện, chẩn đoán và điều trị bệnh, mang ý nghĩa hết sức thời sự và mang tầm chiến lược đối với sự nghiệp chăm sóc sức khỏe toàn cầu cũng như tại Việt Nam. Kính thưa quý vị, Bộ Y tế đánh giá rất cao những nỗ lực, những nội dung được lựa chọn trong tọa đàm năm nay. Từ những liệu pháp thực khuẩn thể để đối phó với kháng thuốc, đến ứng dụng công nghệ in 3D trong phẫu thuật, các đột phá mới trong thính giác hay các xu hướng công nghệ y sinh tiên tiến, tất cả đều là những nghiên cứu trọng điểm nằm trong chiến lược về công nghệ mà ngành y tế Việt Nam đã và đang ưu tiên tiếp cận và ứng dụng. Với sự tham gia của rất nhiều các nhà khoa học danh tiếng ở trên thế giới là minh chứng cho sự nỗ lực không ngừng của VinFuture trong việc kết nối tri thức xuyên biên giới, thúc đẩy khoa học phục vụ nhân loại. Kính thưa quý vị, Bộ Y tế Việt Nam xác định khoa học công nghệ là động lực then chốt để nâng cao chất lượng khám chữa bệnh và tăng cường năng lực của hệ thống y tế. Trong 5 năm vừa qua, giải thưởng VinFuture đã tạo nên những giá trị hết sức to lớn, tôn vinh các nghiên cứu đột phá, truyền cảm hứng cho cộng đồng khoa học và đặc biệt mở ra các cơ hội hợp tác quốc tế thiết thực cho Việt Nam. Tôi kỳ vọng buổi tọa đàm ngày hôm nay sẽ không chỉ dừng lại là trao đổi về học thuật, chia sẻ về kinh nghiệm, mà còn là khởi đầu của nhiều sự hợp tác sâu rộng giữa Việt Nam và các nghiên cứu viên, các trường đại học, các bệnh viện hàng đầu trên thế giới. Đây sẽ là động lực quan trọng giúp chúng ta tiếp cận các công nghệ tiên tiến, triển khai các nghiên cứu chung và mang lại những tiến bộ khoa học để gần hơn với người bệnh Việt Nam. Nhân đây, chúng tôi cũng xin chia sẻ, đây là minh chứng rõ ràng, rõ nét và hiệu quả nhất trong việc thực hiện các nghị quyết của Trung ương Đảng đối với việc đột phá khoa học công nghệ, đổi mới sáng tạo và chuyển đổi số quốc gia của ngành y tế chúng ta. Tôi mong các nhà khoa học, các bác sĩ Việt Nam, các nhà nghiên cứu sẽ tận dụng tối đa cơ hội đặc biệt này để học hỏi, kết nối và cùng kiến tạo những giải pháp về y tế hiệu quả, bền vững và dễ tiếp cận nhất cho người dân. Xin trân trọng cảm ơn Quỹ VinFuture vì những nỗ lực bền bỉ trong việc kiến tạo một diễn đàn khoa học uy tín, lan tỏa tri thức và phụng sự cộng đồng. Chúc cho tọa đàm và giải thưởng VinFuture năm 2025 thành công tốt đẹp. Xin trân trọng cảm ơn.
Thank you so much, Dr. Nguyễn Ngô Quang, for your valuable insights and inspiring words in his opening speech. Distinguished guests, ladies and gentlemen, and now could you please direct your attention to the main screen and let's take a moment to the introduction video about our topics today of the symposium, and as well as get acquainted with our chair and also the distinguished speakers through a brief video. Video, please.
Humanity is facing increasingly complex medical challenges. Infectious diseases continue to spread insidiously, antimicrobial resistance is on the rise, while neurological and sensory disorders are becoming more prevalent in the context of global population aging. According to the World Health Organization, WHO, more than 1.5 billion people worldwide live with varying degrees of hearing loss, among whom approximately 430 million suffer from severe impairment. In addition, antimicrobial resistance has emerged as one of the greatest public health threats of the century, directly responsible for over 1 million deaths each year worldwide. Meanwhile, cancer remains the leading cause of mortality globally, claiming nearly 10 million lives annually. This cascade of challenges highlights the urgent need for breakthrough therapies rooted in biotechnology and next-generation medicine. In this context, science needs open platforms for dialogue spaces that bridge knowledge and foster pioneering solutions for the future of global health. With the aspiration of science for humanity, the VinFuture Foundation proudly presents the Symposium, Advances in Disease Detection, Diagnosis and Treatment. The chair of the symposium is Professor Quarraisha Abdool Karim, Center for the AIDS Program of Research in South Africa, Columbia University, USA. She is the president of the World Academy of Sciences, laureate of the VinFuture Special Prize 2021 and Lasker Bloomberg Public Service Award 2024. The symposium had the presence of distinguished scientists in the field of biomedical sciences, including Professor Pascal Cossard, FRS, Pasteur Institute of Paris, France, recipient of the Louis Jeantet Prize for Medicine, 2008. Professor Ngoc Minh Do, University of Illinois at Urbana-Champaign, USA, and Vin University, Vietnam, member of the VinFuture Prize Pre-Screening Committee, director of the VinUni Illinois Smart Health Center, and recipient of the NSF Career Award, 2003. Professor Ana Belén Elgoihen, University of Buenos Aires, Argentina. She is Fellow of the World Academy of Sciences and Laureate of the L'Oréal UNESCO Award for Women in Science, Latin America, 2008. Professor Chuan Bin Mao, the Chinese University of Hong Kong, China, scientists within top 2% worldwide most highly cited researcher in biomedical engineering field. And Professor Trung Dung Tran, CEO of the VinMec Healthcare System, Vin University, Vietnam, President of the Vietnam Association for 3D Technology in Medicine. He is a leading expert in joint and bone cancer surgery and a pioneer in applying 3D printing technology in orthopedic surgery. Aligned with the overarching theme of the 2025 VinFuture SciTech Week, Rising and Thriving, this symposium will provide a platform for scientists to share the latest advancements in disease detection and treatment, envisioning a healthier and more humane future for all humankind.
Thank you so much for your attention on our introductory video clip. Ladies and gentlemen, and now please join me in welcoming to the stage Professor Quarraisha Abdool Karim, Center of the AIDS Program of Research in South Africa, the chair of today's symposium, to deliver the introductory speech about our topic, Advances in Disease Detection, Diagnosis and Treatment. So professors, please.
Xin chào mọi người, chào mừng. Your Excellency, distinguished guests, friends and colleagues, it's a real honor and privilege to have the opportunity to chair this very special session that we are looking forward to sharing with you distinguished speakers. You've heard a broad outline now of what you're going to be listening to. This is a momentous occasion. We meet at a very interesting point in history where medicine and our advances in science has moved us from an era of serendipity to the discovery of small molecules that had broad applications for many health challenges facing us, onto more precision medicine and precision health that follows from the Full Human Genome Project. And while we're on the cusp of transformation, we are also facing many challenges. At this conjuncture, we are seeing a convergence of challenges relating to climate change. We're seeing challenges relating to the increasing spates of epidemics and pandemics. We are seeing wars and conflicts that have resulted in more displaced populations than ever. COVID-19 was a reminder, as do wars and conflicts that result in displaced populations, that infectious diseases are no longer a threat for the global south alone. They become global threats. We are also reminded at this point in time that many of our challenges are within the context of social media. And we've seen how social media is being used to amplify mis- and disinformation. And we are seeing a blurring of scientific evidence with political opinion. In fact, we're seeing the politicization of science, and we are also seeing the weaponization of science. So there's huge responsibilities on us as we generate knowledge, and to be true to the VinFuture tagline that science serves humanity. We need science that unites rather than divides. We need science that fosters partnerships that are based on mutual respect and trust. Science that brings synergy, where together we're able to elevate the knowledge generation process above and beyond what we could individually, in our individual countries, in our individual disciplines. And that is what this morning's opportunity provides to us. It provides an opportunity to garner the new knowledge that is being generated in medicine, in particular, around new diagnostics, around new therapeutics, and also new ways to ensure we can foster preventive and promotive health. Now, in many of parts of the world, including Vietnam, we have a convergence of infectious diseases, non-communicable diseases. So this morning, we are going to see the broad spectrum of that and utilize this opportunity to hear first from our keynote addresses, 4 of them, on advances in particular domains. And then from there, we'll move on to a panel discussion where we'll elaborate some of these new discoveries in these 3 spaces. And then we'll also open up for Q&A. So once again, thank you very much to the organizers for the opportunity to have this special session, to our wonderful panelists that I'm going to hand over to deliver the keynote addresses. And let's use this time to look at how we can come together, in the words of our Honorable Minister, and work towards science that unites, science that advances humanity, and that we utilize new technologies to ensure that everyone, everywhere benefits from these advances, and we leave no one behind. Thank you very much.
Thank you so much, Professor Quarraisha Abdool Karim, for your amazing speech, helping us thoroughly understand about our topic today at the symposium. Ladies and gentlemen, and now it is our honor to welcome to the stage Professor Ana Belén Ngoyen, University of Buenos Aires, Argentina, for the first presentation on Emerging Therapeutic Strategies for Hearing Loss, a Promising Frontiers. So, Professor, it's your time.
Mr. Minister, President, Executive Director of the Foundation, ladies and gentlemen, Xin Tao, not as good as Quarraisha. So according to the World Health Organization and the latest World Report of Hearing loss is one of the major sensory disabilities worldwide. And if not addressed early on, it leads to language impairment, educational impairment, loss of quality of life, difficulty in integration into society, into economics, and it's a huge burden. And moreover, hearing loss in the elderly, we now know that it's one of the main causes leading to cognitive impairment and mental impairment. Now, if we look at some numbers, over 1.5 billion people are affected from hearing loss, and most of them are from middle and low-income countries. The high cost of inaction leads to 980 billion cost annually, and this is the annual combined health expenditure of Brazil and China. And the worst thing is that these numbers are increasing, and it is estimated that if no action is taken, by 2015, the number of people with hearing impairment will rise to 2.5. So what are the causes leading to hearing loss? Multiple factors lead to hearing loss, and this can be widely divided into genetic factors, and we are going to concentrate on those today. But then there's a huge other factors leading to hearing loss, which include biological factors like health conditions or diseases, behavioral factors like listening to high music, and environmental factors. And this is a whole different chapter. I'm not going to go into this today, but it's an increasing problem anyhow. So if we dip into the genetic factors of hearing loss, we know that 1 out of 500 children that are born have a problem of hearing loss. And 50% of this hearing loss is due to genetic causes. The other 50% is due to other causes, infection during pregnancy, etc. From this 50% of genetic causes, 30% are syndromic, so it's hearing loss plus some other symptoms, cardiac, renal, etc. But 70% are not syndromic, meaning that only hearing loss is the symptom. And from the 70%, the majority of hearing loss is of autosomal recessive inheritance. This means that of 2 parents that are completely normal, have normal hearing loss, the child has a hearing problem. Now, if we look at the genetic landscape of hearing loss, there are more than 150 genes that when mutated lead to hearing loss. So it's a huge amount of genes, and it is estimated that probably 300 genes are causative of hearing loss. Most of them are expressed within our inner ear, in the sensory epithelium, some leading to different types of hearing loss, syndromic, recessive, dominant, etc. Now, what is the treatment nowadays for hearing loss? It's mainly divided into 2 main branches. On the one hand, to your right, it's hearing devices, hearing aids, if the hearing loss is mild or moderate. However, if the hearing loss is profound, you cannot use a hearing aid because the hearing aid only amplifies incoming sound. And in this case, what is recommended is a hearing implant. Now, hearing implant has been a revolutionary for hearing deaf people. However, hearing implants don't really recapitulate completely the normal hearing, yeah? Because they only have few channels, and people with hearing implants, although they can hear, they can not really, they have difficulty in language, receiving language, understanding language, and for example, hearing music. So there's still a challenge for those people which are hearing impaired. What's next? And this is very new. gene therapy has come as an emergent therapeutic strategy for hearing loss. And you might have seen this little boy, this little child a year ago all over in the news, who received a pioneer gene therapy which restored his hearing. So what is this new therapy for hearing loss, and what was targeted in these children? It is a gene which is named autoferlin, which is a protein that is essential for the communication between the sensory epithelia and the neurons of the auditory nerve, which send the information to the central nervous system. When this gene is impaired or has a mutation, these children are profoundly deaf. And mutations in the AUTOF gene account for 2 to 8% of profound congenital deafness. Now, several groups, like 4 or 5 different groups, have started a clinical trial to treat patients with this type of hearing loss. What they did is they introduced within the inner ear, with a very, very slight surgery and through the round window, a transgene, the normal gene for this gene, this AUTOF gene, and within a viral vector, an adeno-associated vector. And yes, these people now can hear. These are the 4 papers that came out between last year and this year, giving the results of this gene therapy for hearing loss in these children. It is still under clinical trial, but the results are really amazing. What are the challenges looking forward in genetics of hearing loss? The challenges are really still very big. This is only one gene that is being under clinical trial for hearing loss. As I told you before, there are like 150 different genes that when mutated lead to hearing loss. So, and this is only one clinical trial for one gene. So the next step forwards are which genes should we target, which genes should we look for, which gene therapy strategies, because it will be different if it's a recessive disease compared to a dominant disease, so the gene strategies have to be different. The delivery systems still need some improvement. The age at treatment, the earlier the patients are treated, the best, but we have to really figure out when. The long-term efficacy of this treatment is still don't know. We still don't know, because it's been only 2 or 3 years that these patients have been treated with this gene delivery system, and there are still safety and regulatory issues and ethical issues. So although, I mean, we are seeing a turning point in the treatment of hearing loss, it is promising. This opens an amount of questions that we have to solve in the near future. And thank you.
Thank you very much, Professor Anna Belen and Goyen, for your informative presentation on emerging therapeutic strategies for hearing loss. Distinguished guests, ladies and gentlemen, and now we are moving to our next keynote lecture. Please welcome to the stage Professor Pascal Cossat, Emeritus Professor at the Pasteur Institute of Paris, France, with the second presentation of Fight Against Antibiotic Resistance, Phage Therapy as One Solution. Professor, it's your time. Thank you.
Okay. Distinguished guest, Mr. President, dear laureates, because I know some of them are in the room, friends of all over the world, I'm really, really happy and really thinking that it's a good trial to have a session like that on the future of medicine in this symposium. So I'm going to talk about phage therapy as one solution to fight against antibiotic resistance. In parentheses, this is not my main topic, but I just published a book on phage therapy, and I think there is a high future for that. So, as WHO is every year alarming the society, antibiotic resistance is really growing and is now named as a silent pandemic. I think the data show that the rise of drug resistance nightmare bacteria are really, really worrying. And if you can read my slides, you see that by 250, antimicrobial resistance could be responsible for 1.91 million deaths per year. So mortality is projected to be by around 70% among people aged 70 and older, and they will continue to fall down in young children. So I think this is really worrying. So before going directly into my topic, I would like to remind you exactly what is antibiotics and what is antibiotic resistance. So, antibiotics were discovered in 1928. This date is important. So, what do antibiotics? They specifically target bacteria at specific bacterial features so that bacteria are killed or stopped to be growing. So there are four main mechanisms. Either the antibiotics prevent the synthesis of DNA, prevent the synthesis of proteins, prevent the synthesis of the cell wall, or they permeabilize the membrane so that components go out. So this is antibiotics action. What is antibiotic resistance? It's not you who are resistant, it's the bacteria who became resistant. And they are resistant because the bacteria have developed drug inactivating enzymes, or they modify the target of the antibiotic, or they prevent the antibiotic to go in the bacterium, or they allow the bacteria, they allow the drug, the antibiotic to go in, but there are efflux points which kick out the antibiotics. So this is antibiotic resistance, and the first description of a bacterial strain resistant to penicillin was in 1945. Keep this date in mind. So the first really systematic and beautiful paper carried out and reported about antimicrobial resistance mortality was in Lancet 2022. And this paper really analyzed the antimicrobial resistance in 2019. This paper clearly showed that there were 4.95 million deaths associated to antibiotic resistance. When I say associated, that means the bacteria were killing the patient, but the original disease was not an infectious disease. The original disease was, for example, cancer or some other disease. But this paper was also saying that there is 1.27 million deaths directly attributable to antibiotic resistance. That means the primary disease was a bacterial infection. As you can see on the right, the number of what are the countries which are mostly affected, and I should have put also highlight the Southeast Asia. It starts from Africa, which are the most affected, down to Australia, and after Africa is South Asia. So the two types of colors means associated to resistance or attributable to resistance, and you can see that it is a really dramatic pandemic which is arriving. So what are the bacteria responsible for this resistance? You have Escherichia coli, Staphylococcus aureus, Klebsiella pneumoniae, Streptococcus pneumoniae, Acinetobacter baumannii, Pseudomonas aeruginosa, Mycobacterium tuberculosis, and so on. On purpose, I tell you these names because you heard about Escherichia coli, but maybe you did not hear about Acinetobacter baumannii, which is a bacterium which can confer infections, for example, in the hospital. So I think this is very important that it's not one disease which is associated to antimicrobial resistance. It's many diseases. We have a special type of pandemic which is really arriving at the level of the planet. So after the first WHO global report on antibiotic resistance, there was a request to have a report, a prospective report, which was carried out by Genome Nell, and he predicted in 2016 that there would be in 2050 10 million deaths due to antimicrobial resistance. In fact, following the Lancet paper that I just detailed 1 minute ago, there has been a new Lancet paper in 2024 with a systematic analysis of microbial resistance in the last 10 years with a forecast to 2050. And now, what are the numbers? The numbers are 822 million deaths associated with antimicrobial resistance could occur in 2050. This is really the 10 millions predicted by Jim O'Neill. And the deaths directly attributed to antimicrobial resistance is 1.9 million deaths. This is really terrible. Regions which is highest all-age antimicrobial resistance mortality rate in 2050 are forecast to be South Asia and Latin America and the Caribbean. Okay, so what to do? What to do now? So this article is really describing a lot of things to be done. First, hygiene. This is obvious. Vaccines. I could not give such a talk without telling you that you should get vaccinated against all the bacteria or viruses that you can. New antibiotics. It's clear that we are searching for new antibiotics. Many techniques should be developed to get new antibiotics. We had a fantastic talk yesterday by César de la Fuente to search for new antibiotics. But there is also a strategy which was developed 100 years ago, which is called phage therapy, and that's what I would like to discuss because it is an alternative which has a future, I think. So phage therapy, something is missing on my slide, but okay. So phage therapy is the therapy which uses phages. What are phages? Phages, this is a small name for bacteriophages. Bacteriophages are viruses for bacteria. So they were discovered by Felix Derel and Frederick Twort, bacteriophages, but Felix Derel was the one who really claimed that this could be used to combat infection, to use phages to combat infection. And in 1919, he really proceeded to the treatment of first of one kid, and then through new patients, and then this strategy was used all over the world, in the States, in Europe, in Russia, Poland, Georgia. So you can see the viruses down there. These viruses are specific for bacteria. They would not attack your cells or other cells than bacteria. So, I would like to come back. Okay, so phage therapy has been a big success between, I would say, 1919 and 1948, 1950. Why? Because big antibiotics were discovered in 1928, like I told you. They started to present advantages which seemed to be absent in phages. For example, you could produce bacteriophage in big quantity. They were stable. They had a broad host range, which is not the case for the viruses. And they seem to be much appropriate to treat infectious disease, bacterial disease. But as I told you at the beginning, antimicrobial resistance increased to the point where we are now. So there has been a revival, a renewal in the hope for using phage therapy. And I would like to give credit to Stephanie Stratti in the States, who published a paper concerning her husband, who had an infection by Acinetobacter baumannii, and he was really dying. And she succeeded to get some labs to prepare phage, a cocktail of bacteriophage, to kill this bacterium. And they both published this book, The Perfect Predator, which is a story of phage therapy in Tom Patterson to kill Acinetobacter bacteria. So next, there are other people who have started again to combat and to do systematic analysis of the treatment of patients. And I would like to give credit also to Graham Atfull, who has been really using bacteriophages for the treatment of a patient with a Mycobacterium abscessus bacterium in the lung. You have to realize that he was using highly purified phages introduce that by intravenous route, and the bacterium would kill Mycobacterium abscessus in the lung. Of course, this is not Mycobacterium tuberculosis, the bacterium which is responsible for tuberculosis, but this is a big step. And another big step was also in this paper that he has used. So really, we are in front of a new strategy, but of course there are specific issues that I would like to discuss. First, the regulation to use bacteriophage in different countries are very different. In most countries, it's authorized as a compassionate therapy when all antibiotics are inefficient. When the patient is nearly dying, then you can ask, can I use bacteriophage? So there are really regulations which are different according to country. In Europe, the most advanced countries where phage therapy can be prescribed are in Belgium and recently Portugal. So interestingly, Felix Derel had a friend in Georgia, which was George Eliava, and they somehow created an institute in Tbilisi, and this institute has never stopped phage therapy since 100 years, and even it stimulated what I call medical tourism. People could go to this institute, get their bacterium treated by phage therapy, and you can go to the website, to the Eliava Center, and you will see how much it costs to get your bacterium extracted, tested in vitro in the lab to see whether there are bacteriophages which are able to kill this bacterium, and you can be treated in this center. So France and other European countries are getting organized. We are nearly there. In USA, there are 4 loci. The IPAT, which is a center which had been created by Stephanie Strapti, Innovation, Phage Application and Therapeutic Center at UCSD, the Center for Phage Biology and Therapy at Yale by Paul Turner. There is at the University of Pittsburgh, the group of Graham Hatfull, and at Baylor College Medicine in Texas, there are also a big, big center getting organized to get a library of phages to treat people by phage therapy. So the specific issues are the following. Phage therapy is different from antibiotic therapy. Phages are living antibiotics. The phage amount somehow increases upon infection. The phage infects one bacterium, you produce 100 phages. So in contrast to antibiotics, where the antibiotics is diminishing during the infection, here the phages concentration is really increasing. Phage have in general a narrow specificity. So it is very critical to first isolate the bacterium from the patient, find one or several phages able to kill it in vitro. Phage preparation is critical. It's critical to purify the phages correctly to avoid inflammatory contaminants such as LPS. If you prepare the phage by infecting a mother bacterium, you have the phages, but you really want to get rid of any inflammatory components if you inject, especially by IV route. If you treat, let's say, a Staphylococcus aureus infection on the skin with a bacteriophage, it's not so important. But for the IV route, it's very important. So phage cocktails are generally used because bacteria can become resistant to one phage, but then the other phage can still be active. So this is something that we could discuss longer, but not that resistance to a phage can become an advantage. And I give the example of phage OMK1, which has as a receptor a pump. So when the pump is mutated, the bacterium becomes resistant to the phage, but since the pump is mutated, the bacterium now becomes highly sensitive to antibiotics. So it's a problem which becomes a solution. So I think also, and this is very important for the future, that there is a future for synthetic phages. Okay, you can synthesize DNA in vitro. We know that chemistry is now very powerful. You synthesize the DNA. You put the DNA in a system of transcription and translation in vitro, and you produce virions. This is done. This has been done. And now there are startup companies which are really making these phages and trying to have them as clean as possible to be used for therapy. As soon as I say that, you realize that you can make a variety of phage with different mutations, different specificity, and different mode of action. So I really think there is a future for synthetic phages. And to conclude, I would say that this is a real example of personalized medicine similar to CAR T cells. Maybe I should just remind people who are not aware of CAR T cells. CAR T cells are the cells which are able to treat cancer. So in that case, in the case of a cancer patient, you take off the T cells from the patients, you somehow modify them so they are able to recognize cancer cells when they are reinjected in the patients. So this is a really personalized medicine for cancer therapy. In the case of phage therapy, you need to extract the bacterium, test in the lab whether the bacterium is really sensitive to a cocktail of phages, and then you can treat with the phages. So really, phage therapy is a personalized medicine. So I hope I have convinced you that there is something to be done using phage therapy. And I must say that there is a frilosity among medical personnel to use this therapy, but I think there is a high future for that. And this symposium was to think about the future, and I think phage therapy, there is a future, at least for some of the people who will be infected by infectious disease, bacterial infectious disease. Thank you.
Thank you so much, Professor Pascal Cossart, for your insightful speech on phage therapy. Distinguished guests, ladies and gentlemen, and now we are moving to the third presentation, the third keynote lecture. We are honored to welcome to the stage Professor Chuan Bin Mao, the Chinese University of Hong Kong and director of the Jockey Club STEM Lab for nature-inspired precision medical engineering, with the third presentation on cancer-hunting viruses, the revolutionary promise of phage therapy. So, Professor, please.
Good morning. Today, I'm very glad to have an opportunity to talk about the use of bacterial viruses called phages. We just heard about phage for cancer therapy. Now let us have a little bit more knowledge about the phages. Phages are actually the human-friendly viruses that specifically infect bacteria. They are made of proteins and DNA. As you can see from the size, they are actually biological nanostructures. The DNA inside the bacteria phage, and also called phages, genetically code the protein outside. This is a diagram about the brief history of phages. As mentioned by the previous speaker, phages were discovered in 1917. Over the time, phages have led to multiple Nobel Prizes. Also, in the recent years, phages have been used as biomaterials to develop technologies for disease diagnosis and treatment. That's the focus of my today's talk. So I would like to use this filamentous phage as an example to highlight a little bit more about the structure of phages. As you can see from the diagram, the inside of phage is circular single-stranded DNA for this case. And the outside is proteins. Specifically, it has multiple proteins that are genetically coded. In other words, you can modify the DNA to modify the protein outside. So, for instance, if we can insert one gene to the phage DNA, you can display the peptides on the tip of the filamentous phage. Similarly, if you insert the second gene to the right position of the same DNA, another peptide can be displayed in many copies on the side walls. So in other words, you can precisely place the foreign peptides on the surface of phages site specifically. That's the foundation for developing biomedical technologies such as cancer diagnosis and treatment. So if you allow one phage particle to infect the bacteria, overnight, the copy number of the phage particles will be increased exponentially overnight. So that means you can amplify phages in a short time frame. That's how we make phages in the lab. In other words, if you want to make phage particles, if you want to have a large quantity of phage particles, you only need to allow phage to infect bacteria. So if you think about phages as a drug, you need to have a way to make it. So that's the way we make it in the lab. When solid tumors are growing, some tumor cells may leave the tumor and enter blood circulation. These tumor cells are now called circulating tumor cells, or CTCs for short. Therefore, detecting CTC from the blood is a powerful approach for cancer diagnosis. If you want to use phage to achieve this goal, here's what we can do. So we can engineer the side wall of phages so that the phages can recognize and bind the CTC from the blood. Also, we can immobilize the phages on the surface of a magnetic bead. Then you can add the phage-modified beads into the blood. Then the phage on the bead will capture the CTC. Then we can use a magnet to take the phage-modified and the CTC captured beads out of the blood. After that, we can detach the CTC away from the bead. Then we can characterize the proteins on the surface of the CTC in order to know what kind of cancer cells or what kind of cancer this patient has. Because of the capability for the phage to capture and detect CTC at a higher efficiency, we only needed to collect about 1 milliliter blood from the cancer patients in order to achieve the cancer diagnosis. Next, I want to talk about the use of phages for cancer therapy, including immunotherapy, anti-angiogenic therapy, and photodynamic therapy. To achieve these goals, we need to identify targeting peptides from a phage library. A phage library can be pictured as a mixture of millions of phage particles, with each phage particle displaying a unique peptide on the tip or on the side wall. After we interact the phage library with targets, we are able to identify a peptide that can target and recognize a protein, a cancer cell, or a tumor. If we can achieve this one, we can display the peptides we identified on the surface of the phages. For instance, we can display the tumor-targeting peptide at the tip of the phage. At the same time, we can display a protein-binding peptide on the side wall of phages. Then, after we inject the phages intravenously into the animal models, and the phages can be guided by the peptide display at the tip to tumor. Once phages arrive at tumor, the protein-binding peptide displayed on the side wall of phages can bind and capture a particular protein to trigger disease treatment. Now let's see the first example. So in this diagram, you can see the two peptides we identified are PD-L1 binding peptide and tumor targeting peptide. We display the tumor targeting peptide on the tip of phage. At the same time, we display PD-L1 binding peptide on the side wall of phage. After we intravenously inject the phages into the animal model, the peptide displayed on the tip can guide the phage to home to the tumor. After the phages arrive at the tumor, the PD-L1 binding peptide displayed on the side wall of phages can bind and capture PD-L1 on the surface of cancer cells. This binding will block the recognition between PD-1 on T cells and PD-L1 on cancer cells. This blocking will activate T cells, which is a kind of immune cells, to attack cancer cells. Then the cancer cells will be killed to achieve immunotherapy. So that's why this treatment can lead to the successful suppression of tumor over the time. At the end of the study, if we take the tumor out of the animal models, the tumor sizes for this treatment are the smallest. So let's look at the second example. Similarly, we can identify a tumor targeting peptide and an angiogenic binding peptide. And angiogenic is a protein that can promote blood vessel formation in tumor. After we identify these two peptides, we display the tumor targeting peptide at the tip of the phage. At the same time, we display the angiogenic binding peptide on the side wall of phages. Then we can inject the phages into the animal models. Then the tumor targeting peptide displayed on the tip of phages can guide the phage to home to the tumor. Once phages arrive at the tumor, the angiogenic binding peptide displayed on the side wall of phage can capture and recognize the angiogenic, which is a protein secreted by cancer cells. Once angiogenic is captured by the phages, it will no longer be available for promoting the blood vessel formation in tumor. Once this occurs, the blood vessel density in tumor will be significantly reduced. As we know, tumor cells need the blood vessels to deliver the nutrients and oxygen to the tumor. Once the blood vessel density is decreased significantly, the tumor cells will feel hungry and die. That's the way how we treat cancer by this method. In other words, here we are using the phages to inhibit the blood vessel formation so that the tumor cells can starve and die. So that's why this treatment can successfully inhibit the tumor growth over the time. At the end of study, we take the tumor out of the animal model, then we find the tumor size are the smallest for this kind of treatment. We also identify a material binding peptide, then displayed on the side wall of phages. If you can do this one, the side wall of phages can induce the formation of inorganic nanoparticles on the side wall of phages. This will allow the phages to carry the inorganic nanoparticles, then home to the tumor. Once the phages arrive at the tumor, because of the unique peptide displayed at the tip, which is the tumor homing peptide we identified. This peptide can guide the nanoparticle-coated phages to enter the cancer cells. Once the phages are inside the cancer cells, the inorganic nanoparticles on the side wall of phages can serve as a catalyst to catalyze the reaction that leads to the production of oxygen inside the tumor cells. So this will promote the increase of oxygen level in cancer cells. Why this is important for photodynamic therapy? Because photodynamic therapy needs the presence of oxygen to work, to trigger cancer cell death. Because for photodynamic therapy, you need light, oxygen, and a photosynthesizer. Normally, tumor lacks oxygen. So that's why we need a way to promote the formation of oxygen in tumor to increase the oxygen level to generate the tumor-killing phage. So these two articles are published to celebrate the 100 years celebration of phage discoveries. So these two papers discuss how we can identify tumor-targeting peptides, protein-targeting peptides, and also how we can use phages for treating cancer and diagnosing cancer. If you are interested, you can read these two articles. Finally, I would like to summarize these four unique features. As you can see from my talk, phages are cost-effective because we can turn one into millions of copies. Second, phages are highly reproducible because we use bacteria as a factory to mass produce them, to replicate them. Third, phages are genetically modifiable. For instance, we can insert a gene to display peptides. That is the one way to functionalize the phage so that the phage can capture target cancer. Lastly, based on the phage therapy study published so far, phages are human-friendly. If you are interested in collaborating in this direction, I welcome you to contact me and visit my lab in Hong Kong. Here is our beautiful campus, and this is my contact information. If you scan these QR codes, you can get connected with me. Thank you so much.
Thank you so much for your invitation, and thank you so much for your insightful speech and presentation. Professor Tuan Bin Mao. Ladies and gentlemen, and now it's time for us to go to the final keynote lecture. And I would love to welcome to the stage Professor Chung Dũng Chen, CEO of VinMec Healthcare System, Chairman of the Department of Orthopedics at Vin University, Vietnam, with the presentation on In-Hospital 3D Printing Technology, a breakthrough in orthopedic surgery. So Professor, the stage is yours.
Hello. Dear distinguished guests, okay, I'm very honored to be here to introduce about in-hospital 3D printing technology, a breakthrough to orthopedic surgery. So my background is an orthopedic surgeon. So in my daily clinical activity, I have to deal with so many challenging cases with massive bone loss, with some causes like trauma, or arthritis, or revision case, or especially is some bone cancer that we have to perform the wire resection. And traditional implant sometimes did not reconstruct anatomically, and you can see on the right side is sometimes we have to combine with many methods with the implant and bone grafting, or even sometimes we have to use a cement, biological cement. And on the right side is a reconstruction with for the pelvic and the proximal femur with the implant we print out from the our 3D lab in VinMec and VinUni. So anatomic reconstruction, I think that will be the best. For example, for some complex anatomic region, for example, the pelvic, because the pelvic is not only the anatomic component for the hip joint, but also the support support component for the to hold the organ in the abdominal. And for bone cancer, almost we have to perform the wire resection of bone cancer. And this is the difference between the Asian culture and the Western culture. In Western culture, the patient and family may be easily to accept the amputation, but in Asian culture, especially in Vietnam, it's quite difficult for the patient and for the family to accept the amputation. And in last research by my team in the period of 2015 to 2017, 30% of patients with amputation indication, they left the hospital and never come back because they don't accept the amputation. Okay. 6 years ago, we have to deal with a very complicated case with bone cancer in the proximal femur. And we have to perform a combination technique between the implant and an artificial bone print out by the PEEK material. It's quite successful 6 years ago. And 5 years ago, we have to deal with another more complicated case with the bone cancer of the pelvis, and that requires an implant, a pelvic implant that's personalized to the patient. And we have to cooperate with the 3D lab approach and to print out the implant. But you can see on the right picture, we can see the mismatch between the implant and the bone of the patient. Therefore, we have that lead to the necrosis of the skull. Thus, we have to perform the second surgery to use a flap to cover for the implant. It means that's the collaboration between the 3D lab and a group of surgeons is very familiar with the other center. But you can see that's because of the distance and the no, we don't have the in-person communication and discussion between the surgeon and the engineer. So that's sometimes we don't have the perfect implant for the patient. Like this case we did 5 years ago. And from that on, we do a lot with the combination technique for the total femur replacement or the total humerus and some other joint. And we think that for some very special cases that we have to need the personalized 3D printed implant. That's we don't have the available product. Therefore, from the 2022, we, Vinmec and Vinini, we established a 3D printing lab located in Vinuni. This is some picture about our machine. And 2 years ago, this is a quite difficult case. It's a bone cancer of acetabulum pelvic invaded to the head and neck of the femur. And the principle, we have to perform the wide resection. It means that we have to perform the amputation, include the pelvic, or we have to perform the wide resection and reconstruction for the hip joint. And with the support from the R3D lab, we choose the second option. It means that we have to perform the wide resection for the bone cancer and then reconstruct the 3D printed implant from R3D lab. The video illustrates how we perform the surgery. And you can see that we have use PSI. It means the patient specific instrumentation to support for the cutting guide to get the perfect accuracy. Therefore, when we put in the implant, you can see the bed fit for between the implant and the bone of patient. This is some image intraoperative, and you can see on the CT scan post-operatively, we can have the perfect accuracy between the implant and the bone of the patient. And this is some video for patient after the 6 months and 12 months. The function quite good, and after follow-up, after two years, and then no recurrent or the metastasis of the cancer. And 1 year ago, another case quite difficult is on the left side. The previous patient is on the right side, and this one is on the left side, but the tumor invaded to the ischium. So we have to design a new implant for the pelvic. And we have to measure and pronounce all the screws that we put in for the patient. And this is some image intraoperative, and you can see here on the left-hand side, the CT post-operative. And this is the movement of patient after 6 months. So another case, we performed nearly is the bone cancer of the proximal femur with the quite small femur. And then we have to design and pronounce the proximal femur from our 3D lab. And this is some picture of designing, and this is the CT post-operative, you can see. And not only for the pelvis, we have to perform some, pronounce some product for some other cases. For example, this is bone cancer for the total femur in a child 8 years old, and we pronounce the femur with the hip joint and the knee joint for him. This is maybe the youngest child we perform the total femur in the world. This is the video after 1 month. And then some of the other product we print out from the RTD lab for TMG joint and the sternum replacement or the mandible bone replacement or the talus or the skull. And I think that in the future, this is a good chance for us. I mean, that's the doctor, the surgeon, and the engineer, we have a good chance to deliver the better option, the better solution for some patient like this with the massive bone loss. And some other some other technology we engage to the 3D printing technology is that AI and patient can be easier to assess with this solution. And how to, the most important thing in 3D printed implant is just the costing. And how to reduce the cost, we have to do some solution to address this problem. We have to scale up by networking with so many other doctors, so many other surgeons, and so many other center, university, hospital, to make a network so that when for one time we can print out not only one implant, but also but we can print out the 10 or maybe the 20, so that we can help to reduce the cost. And we gather together all the doctor, engineer, businessmen, and the other, they are very, they want to apply the 3D technology in association, Vietnam 3D Technology Association. And then we do some activities such as education, research, and transfer new technology to the other medical center. And this is the network of our group in Vietnam, so with so many other university and hospital. Okay, thank you very much for your listening.
Thank you so much, Professor Chung Dũng Chen, for your amazing presentation. Distinguished guests, ladies and gentlemen, and now I would love to kindly invite all of you to be with us on a cultural journey titled Exploring the Essence of Vietnam Heritage, featuring with our distinguished speakers and especially our council members. Let's go. Thank you so much for your attention on our incredible journey of our distinguished guests, and especially council member. They themselves experience the culture of Vietnam, our country, just 2 days ago, and we hope that you will have a great time in our country, Vietnam. And now it's time for you to have a quality time for the panel discussion. And now it is my honor to welcome back to the stage Professor Quarraisha Abdool Karim, Professor Pascal Cossart, Professor Anna Belen Ngoyen, Professor Chuan Bin Mao, and along with our distinguished speakers, Professor Ngoc Minh Do, University of Illinois Urbana-Champaign, USA, Vinh University, Vietnam, to be on the stage for the symposium panel discussion. Please welcome our distinguished panelists and chair. And also the Professor Quarraisha Abdool Karim, who moderate the panel discussion today. And professors, it's your time. Thank you.
Longer. So before I do anything, I think all of our speakers need another big round of applause. I also want to welcome Mindu. We've not heard from him this time, but also I think what you see on the stage is this transformation of knowledge generation, where we're not working in narrow silos, but where different disciplines are coming in. And we've seen several examples here of different medical disciplines and life science disciplines coming together. But we're also seeing how engineering and particularly material sciences are coming in, the importance of multidisciplinary research. We had a little glimpse yesterday of the role of AI. So to kick off, I wanted to pose a question, which is generally from the time you have an idea and a discovery in the lab to get to the bedside and benefit humanity is not a short journey. On average, it takes about 7 to 20 years, let's say, not an average, it takes about 7 to 20 years. So Pascal, maybe I'll pose the first question to you, which is, as you were talking about use of phage therapy for antimicrobial resistance, how far are we from the ideas you presented to actually having that in our practices, in hospitals, in clinics across the globe?
Well, can you hear me? Can you hear?
Yeah.
Can you hear? Okay. So I have tried to tell you that the situation is very different in different countries. For example, in Belgium, a medical doctor can say that he would like the patient to be treated by phage therapy. In France, it's totally impossible. But what is the problem for phage therapy at present? There is a word that I did not say, it's solid clinical trials. There has not been enough clinical trials which have been done to really say phage therapy is successful all the time, phage therapy is secure and everything. So I think there is a need for that. But we have seen during the COVID that clinical trials can be made very quickly if efforts can be put in that direction, if the state money is put in this direction, and I really think there is a future for this therapy if clinical trials are made. So you ask me when, I say it depends on country, and if I can add something, I think we have to be aware that curing from a bacterial infection can be done, for example, via antibiotics or via phage therapy, but we should not forget that the immune system is also playing a big role. If you kill a bacterium or if you prevent the growth, then the immune system has to somehow eat the debris or eat the bacterium. So we have to think that it's not only the antibiotics or the phage which will be important, we have to also think about the immune system. And that's why it was said that the problem of antibiotic resistance will affect all people because their immune system is very low. So we have to think maybe of using both antibiotic and phage therapy for older people or for people who have an immune system which is low. So since I've talked enough, maybe I'll leave the comment.
Thank you very much. I'd like to move on to Professor Chunbin Mao, and perhaps you can comment. I mean, when Professor Cossart presented, he left us with that intriguing thought that unlike antimicrobial resistance due to antibiotic use, that resistance can actually, in phage therapy, be an advantage. And I wonder whether you could expand on both aspects of when can we expect all of this to be part of routine service provision, and how do you see this field emerging and evolving?
Okay, I personally have worked on phage for about 20 years. So one of the most promising fields for phage therapy is the use of phage for treating antibiotics-resistant bacteria. So there has a lot of published work on the use of phage for treating bacteria. And actually, when phages were discovered, people think the phages are something that can kill bacteria. So that's how phage was named in Greek. And so basically means something that can eat the bacteria. So in other words, when phage were discovered, people already know phage can kill bacteria. And later on, people found there are phages that can kill bacteria. There are phages that cannot kill bacteria. The phage that can kill bacteria, we call lytic phage. That means when phage infect bacteria, it will kill them. So like the phage I talk about today, filamentous phage, normally is non-lytic. Non-lytic means it infects bacteria, but it will not kill bacteria. So anyway, so traditionally, when people mention phage therapy, it just means the use of phage for treating bacterial infections. But now, over the time, we expand the concept of phage therapy. Traditionally, phage therapy means the use of phage, lytic phage for killing bacteria, for treating bacterial infection. And then now today I'll talk about the use of phage for something beyond the bacterial infection treatment. It is cancer diagnosis and the cancer treatment. In fact, we are also working on the diagnosis and the treatment of other diseases, in fact, actually. So I should say the most promising application of phage is immediate, in the near future, I can see a clinical application is the use of phage for treating bacterial infection. But in the future, so I can see the use of phage for cancer diagnosis is very possible to use in clinics. And later on, the use of phage for cancer therapy. So like today I talk about immunotherapy, for instance. We all know immunotherapy is used in clinics. However, the success rate is not 100%. So the response rate is not very satisfactory. That's why we try to use phages to do immunotherapy. But the advantage of phage is we can engineer the phage so that the phage can target the disease site or the cells or the proteins. So this targeting is very important for disease treatment, in particular for cancer therapy. Like today I talk about PD-L1 in treatment, immunotherapy. PD-L1 therapy is one kind of immunotherapy. However, in traditional in PD-L1 therapy, people use antibody that can bind and recognize PD-L1. But that technology has problem because PD-L1, which is a protein, is not just existing on the surface of cancer cells. It is also existing on normal cells. That means the molecule we are targeting are existing on both cancer cells and healthy cells. So you need a way to target, make sure the drug only go to attack the PD-L1 on cancer cells. That's where phage can play a significant role. Traditionally, people inject just antibody into the human body because this antibody recognizes PD-L1, but the PD-L1 is on both cancer cells and normal cells. You can imagine the traditionally used antibodies can go to the tumor, can also go to the healthy tissue. This will go lead to the side effects because when the PD-L1 recognizing antibodies recognize PD-L1 on healthy cells, that will cause side effects.
Thank you very much. So we know what we can anticipate in the near future. I just wanted to move the discussion now to another facet. And a lot of what we've been hearing and will continue to hear in the VinFuture Week is about science in service to humanity. And we know that there are huge inequities and inequalities from the time you have an innovation to everyone who needs to benefit from that innovation having access to that. And Bellum, I wonder whether I could turn to you to maybe use the example of hearing loss and some of the advances you spoke about, and how we can accelerate that closing of the gap of innovations to benefit everyone who needs to benefit from that.
Is this working? Yeah. So that's a huge problem, I think. I mean, technologies are great, but they are not cheap. So gene therapy in general is not something that is cheap. So even when it is approved, probably not everyone will be able to get a gene therapy, in this case for hearing loss or sickle cell anemia, which is already in clinical use, or muscular atrophy, spinal muscular atrophy, which is already in the market. So we are moving forward, but we're also making a more non-fair world. That's my way of seeing it. But that doesn't mean that we don't have to move forward. If we look in the case of the cochlear implants, which have been in clinics for a long time, I mean, low-income countries and people which can't afford them don't get a cochlear implant. And this has been around for a long time. So this is a huge problem. Inequality in general is a huge problem. Yeah.
I was thinking, Bellum, about one of your slides where you showed that about 50% of hearing loss has a genetic basis. And the other 50% actually comes from infectious diseases and other causes. And so I was just looking at this balance between rushing to new tech and then some basic things that even Pascal referred to in terms of minimizing antibiotic resistance, in terms of hygiene and vaccines and so on. So I wonder whether you and Mindu maybe would like to comment a little bit on that?
Yeah, I want to leave a message because I talked about gene therapy, but for genetic diseases, but the other 50% of hearing loss is not genetics. It's not of genetic origin. And although antibiotics are one cause leading to hearing loss, it's only few antibiotics, which are the aminoglycosides, which are not used in every country, maybe in poor countries. But the main cause, non-genetic cause leading to hearing loss is the exposure to loud sounds. When we go to a concert, where we are in traffic in these big cities, and this is a huge problem. The exposure to loud sound is the main cause leading, an ambient cause leading to hearing loss. And it's a very easy way to avoid this hearing loss. That's protection. I mean, avoid being in loud ambient noise, or if you have to, if your work is in a high noisy environment, like if you're working in an airport, you have to protect, and that's the best way. Prevention is the best way not to get noise-induced hearing loss.
Thank you. And if you were here yesterday in the session on AI and trust, there was a really inspiring and mind-blowing presentation by Cesar de la Fuente on how he is using AI to accelerate drug discovery. And then this morning we heard about 3D printing and restoring movement and mobility and so on. And I wonder whether, Professor Tran, you would like to comment on how we can better leverage AI to accelerate progress in biomedical sciences and health in particular.
Okay, thank you for your question. As I mentioned in my presentation, that's the problem for AI printing is just the costing. So how we can reduce the cost? We have to accelerate the time of designing. So far, we use the AI to support for the engineer in designing. For example, for the one sample, normally one engineer, they have maybe 2 or 3 days for designing. With the support of AI, we can reduce less than 2 hours. It means that we can have many more design in a short time. And then that's for one time of printing, we can print out not only one implant, but maybe we can print out the 10 or 20 implants. That's the way we do to reduce the cost.
And Mindu, you really straddle this engineering and biomedical sciences and innovation. And I wondered whether you'd like to comment. For example, in COVID-19, our most recent pandemic, and unlikely to be the last, AI was leveraged multiple times in terms of containment and transmission. So maybe you could talk a little bit more about how AI can be used in pandemic situations.
Thank you. Yeah. So my interest and also the mission of the VinUni Illinois Smart Health Center is how can we provide healthcare, the next generation healthcare at scale. And particularly we would like to focus on providing, connecting the patients continuously with their healthcare provider. I think you mentioned about yesterday, we heard from VinSurf, the godfather of internet, and also a VinFuture Prize Laureate, reminded us how internet began, right? It's just a group of graduate students get together, build something that connecting diverse, interoperable devices in a trusted and reliable way, which then can be scaled and can transform the whole world. And I really think we have an opportunity to do so to transform healthcare. examples, just give you one example, and I will come back to the COVID example. But there is one of the hottest company in the AI for healthcare space now is named by is by the name Open Evidence. So basically, they are chat GPT for physicians. And in February this year, they was valued as $1 billion. And by July, they value $3.5 billion. And last time, the next round of investment in October is $6 billion. They already gathered 16 million clinical consultations within the last year. So that technology, I think, can easily scale. And you can imagine that kind of tool could be in everyone's fingertip, right? And people around the world. We're talking about billions of people that have a very little access to regular doctors. And I think, the COVID also showed maybe the next wave, how can we provide this continuous monitoring and connections beyond just simple text inquiry, but maybe with point-of-care diagnostics. Right? You can take your test at home, but now beyond infectious disease, maybe early cancer detections or other type of diseases, or continuously provide the feedback to the doctors, would have an AI in the middle to scale and provide that continuous service.
Thank you. So before we move to open Q&A, I'd like to give you 30 seconds each, literally 30 seconds on 2 points. The first is that, we are all about service to humanity in our knowledge generation process. The Sustainable Development Goals that all UN member states have committed to, we've not made much progress, and our 2030 timeline is coming up. And at the same time, we have all these discoveries that keep coming, and we have to counter that with this mistrust and distrust. And so if we're really going to realize the potential both of accelerating progress on sustainable development goals and to ensure that the public is committed to utilizing our discoveries, what would your 30-second comment be? And I'm going to start with you, Tran.
Well, I think that's let me talk a little bit about my whole story, not only the 3D printing. That's because you mentioned about the sustainable. 80% of our product from our 3D printing lab, that's for the bone cancer. And the story of bone cancer in Vietnam is, I think that's maybe similar to the other country. Bone cancer is a rare cancer. So not, especially in Vietnam, and not too much attention to the bone cancer, because in the past, all the time, the doctor, the surgeon, think about the bone cancer is amputation, and nothing can do for him, for her. So we established a sarcoma center in VinMec and in VinUni, a comprehensive team to care for the bone cancer, almost bone cancer. And every year we perform about 1,000 cases. We are maybe the number one for bone cancer treatment in Vietnam, 100. But not only the surgery, not only the 3D printing. We set up a comprehensive team between the surgeon, the medical oncologist, and the researcher, and the engineer from 3D lab. And then all the sample, all the tumor after virialization, we store in our biobank. And we create a network for study about the bone cancer, and not only in Vietnam, but also in other countries, Japan, Korea, and some from US. And we, because I'm a surgeon, so I introduce more about the 3D printing implant. but we have some other direction of research focus on maybe the cell therapy or something we think about the immunotherapy or maybe the vaccine for oncology vaccine. It means that, and then parallel with the sample stored in the biobank and some research, we also collect all the clinical data, and we can use it to compare with the research data, and then we think that we can figure out something new. And so far we have find some very specific gene for sarcoma patients in Vietnam with a collaboration with some colleagues.
I think we can pick up on that in a little while, but in the interest of time, let me move on to Bellum. Thank you.
So I think that, for sustainable development, we need healthcare, accessible healthcare, at least minimal healthcare for all. Not all people, the wealthier countries have healthcare, but not all countries. So I think we have to move back from all this technology and the minimal healthcare accessible to all, and also educate people, because educated people, not everybody gets education, and if you don't have education, you don't go and reach for healthcare when you need it. So it's more basic than technology.
Okay, so to talk about science communication, I think it's very important that not only the lay public, but the politicians are aware of where the science is, because science can progress also if there are money to have the progress going to really healthcare and going to the patients. So I think there is not a single country where if there is no money, there can be something done. So both scientists should go to the public, talk about, explain the science, the progress, what can be done, and the politicians should also be aware. So the politicians were kids in the first place. So I think we should start the education really from the basic level up to the top. And I know that in my country, for example, the politicians very rarely know about things. For example, I was mentioning antibiotic resistance. I know, I gave a very basic slide. But some people think that people become resistant to antibiotic. No, it's the bacterium which become resistant to antibiotic. So I think there are basic science which should be taught to the politicians so that money can arrive to the scientists and that progress can be done.
Okay, I think now science becomes more multi and cross-disciplinary. To advance science, we needed to have people from different backgrounds, from different countries, to collaborate and work together. In particular, for the medical research, we need fundamental scientists, the engineers, and clinicians to collaborate and actively talk to each other and to advance the disease diagnosis, prevention, and treatment.
So I have the perspectives from both living in the US and in Vietnam. From the US perspective, it's well known now the biggest socio-economical problems now is the healthcare. It's very expensive, very inefficient. And let me give you a story. So on the way coming back to this event, I was sitting next to a passenger on airplane, and he's a investor in AI for health. Right? He mentioned his companies last year invested $18 billion in a variety of companies, and he happened to be an alumni of University of Illinois where I was. So we connected and we talked to each other. And I shared with him my research. And he said, well, I can easily, with the UIUC branding, can easily help you to raise a couple $1 million to have a startup to commercialize this technology. And then I told him about the healthcare landscape in Vietnam, and that's where I'm going to, and I'm going to have a collaboration with university and hospitals and so on in Vietnam. And he's so excited. He said, well, then forget US market, concentrate in Vietnamese market first. Because he understands there's so much of regulations, a lot of special interest groups like healthcare, providers, medicals, device giants, insurance companies, IT vendors, they all have their special interest and they lock into the healthcare system in the US, make it very difficult to innovate. Whereas a country like Vietnam, with a fresh start, and hopefully with a better political systems, allow a lot of innovation. We talk about healthcare, a lot of the time it starts from an advanced country and then it trickle down, right? Sometimes healthcare at scale may be innovated first in a developing world. And then it can test out and find out the right model, which then can be demonstrated to the advanced country like US. What would be the optimal healthcare system should be?
Thank you very much. Now, you can see we have very enthusiastic speakers here, and time is against us. And I hope that in the course of the next day or so, you will engage more with them. But it gives me great pleasure to thank all of them again and to hand over to our program director.
Thank you so much, our chair, and thank you so much, panelists. And now it is time for the audience to deliver the questions. I'm so sorry that because of limited time, so we have just one spot for the very last and only one questions from the audience. So I want to see your hand waving. Yes, please. Yes, the lady in black.
Okay, so thank you very much for giving me the chance. So thank you very much, the panelists, for your inspiring talk and very insightful. And actually, it's now becoming very apparently that biotechnologies become really got a great impact on human life. And our government also recognized their importance. And so, since last year, we have a lot of strategies to improve the biotechnology and call it as a priority in Vietnam. And so, so I'm from Vietnam National University in Ho Chi Minh City. And just Saturday, or last Saturday, we also organized what we call the strategics, a conference on biotechnology. So we would like to figure out what is the strategies to development biotechnology in Vietnam. And so it is also organized between the government, the politics, and also scientists, and local scientists, and also the industry. So to figure out what should be the strategic biotechnology. And so my question is that, so we would like to hear from a great scientists like you, to hear your advice on, because our country is kind of still in a limited source, so we cannot invest for all sector biotechnology. Biotechnology is so vast, so immense. So according to opinion, in the next 20 years, what should be the core technology in biotechnology that we should invest? As Professor Ann has said, technology, particularly biotechnology, is so costly. And so which kind of the core technology we should invest, particularly in the field of biotechnology and biomedical field? What should we select? Which field should we select in order to invest for the next 20 years? So that, because normally the community always wants us, the scientists, to have achievement in a short time to show the people. And so it's very difficult. And so what can we do in this kind of very critical time point in science development in Vietnam now? So thank you very much.
Thank you for your questions. So the chair, who will be the one to answer these questions?
Why are you being so mean to me, giving me the most difficult question?
Yes, just one professor will answer.
I wish we had a magic wand, but the points that you raise is really important, that politicians need an answer today. Scientists are forward-looking. So we have to anticipate what is the politician 10 years from now, what answer is he going to need from us. And I think it really depends on a number of factors. And I think particularly for developing countries, I would say, what is the leading cause of disease and death in your country? And prioritize the science around solving that solution, solving that problem. Be very focused, really drill in so that you have a very granular understanding of the issue, and that, as you've heard repeatedly, these solutions, they don't come quickly and easily. So we have to think ahead, plan ahead, and be ready so that we're not behind in terms of the answers we're going to need. Thank you.
Thank you so much, Professor Quarraisha, Abdool, Karim. Thank you so much for your questions from Vietnam National University. Thank you so much for travel that far to come to our event today. One more time, thank you so much for our distinguished speakers and our chair, and also our panelists for the very active participation in the panel discussion. And don't forget that we still have 3 rooms for the scientists can network and connect with each other with 3 assigned topics. And the session will last 30 minutes until 11:35. One more time, thank you so much, our panelists, and thank you for your attendance, our audience. And don't forget to watch VinFuture Prize Award Ceremony will live broadcast in VTV1 Vietnam National Television on December the 5th. Thank you so much one more time. Goodbye for now and see you this afternoon.